And our next speaker is Michael Liu. Dr. Michael Liu is the Senior Associate Dean for Academic Student and Faculty Affairs at George Washington University Milken Institute School of Public Health. Dr. Liu provides leadership and vision for the school's educational mission and coordinates services and support to help all children and faculty succeed. Prior to joining GW, Dr. Liu was the director of the Maternal and Child Health Bureau for the U.S. Department of Health and Human Services from 2012 to 2017. He led a federal bureau with an annual budget of more than $1.2 billion that served more than 57 million women, children, and families nationwide. During his tenure, Dr. Liu transformed key federal programs in maternal and child health, launched major initiatives to reduce maternal, infant, and child mortality in the U.S., and was awarded the prestigious Herbert H. Humphrey Award for services to America. And so we are really, really pleased to have Dr. Liu fight the traffic in Washington, D.C. and come and see us here and share with us.
Good morning.
Good morning.
Let me start by thanking Dr. Bilcher for the invitation and for your lifetime of leadership and service to maternal and child health. I've admired your work for such a long time, so truly an honor to be invited to speak here this morning. And Dr. Bilcher asked me to come and talk about my life and my career and maybe share some lessons learned along the way. Now, you know you're like getting old when people start asking you to like share your life lessons. I certainly just hope that I can learn enough along the way to make it worth your while. So I'm going to take us back 52 years to Taipei, Taiwan, where I was born. So this is a picture of me as a baby, the only picture I have of me as a baby. You see, I was born to two parents who never went to college. In fact, my mom never went to high school or even junior high. See, my mom was only 11 when her father died. So as the oldest girl in the family, she had to drop out of 5th grade to go work in the factory to help support the family. So when they first got married, my parents were still pretty poor. The first house that I was born into, we had no flush toilet, no running water, and we had no health insurance because there weren't such things as health insurance back then. And so when you got sick, you never knew how much the medicine or the doctor was going to cost. And unfortunately, I was sick a lot, and so my parents often had to make the choice between paying for food or paying for medicine. And at one point, my mom sold her wedding ring to pay for my medicine. So certainly, I didn't come from wealth or privilege, but there was probably something else that I got from my family, from my background, that was perhaps more valuable. So I learned everything I ever needed to know about hard work, about sacrifice, about grit from my dad. And I learned everything I ever needed to know about love and compassion and empathy from my mom. They worked hard all their lives to raise a family and to put food on the table, put 4 kids through college, and to see their youngest son go from that tiny little apartment on the other side of the tracks in Taipei where a family of 6 was crammed into, to be invited to speak this morning on one of the most hallowed grounds in the history of medicine and public health. I used to think that I beat the odds despite my background. But as I get older, I'm beginning to realize that perhaps I beat the odds because of my background. Yes, this is a story of resilience. It's not my resilience. It's a story of intergenerational resilience. And it really isn't that uncommon a story. If you listen carefully, You'll find it in many of the immigrant families that you take care of. Families who left everything behind, set forth for a distant shore, looking for better opportunities for their children. And families that you take care of who are raising kids with special health care needs, fighting battles every day to give their children a fighting chance of reaching their fullest potential. So if we're really going to improve maternal and child health in the country, there's actually quite a lot that we can learn from families about where resilience comes from, but only if we're willing to listen to their stories. In my background also gave me a clear purpose for life. And that may perhaps explain what I ended up doing with my life. It gave me a North Star to follow. And that is to work hard every single day to give every girl, every child, every family a fair shot of reaching their fullest potential. Kind of fair shot that my mom never had. And the kind of fair shot that too many girls, too many kids in this country and across the world will never get. I have to say it's been a nice North Star to follow. That from time to time, I lose my way and get all caught up in pursuit of fame and status and wealth. That I have to catch myself and make sure that I don't go too far off track from that North Star. So the one thing I would encourage you to do, if you haven't done it already, is take some time this week, when you get a moment, write down your mission, vision, and values, and then go back once in a while to check on it, to make sure that you're still doing what you set out to do. So I think it is important to anchor your life with a clear purpose. So we came to this country when I was 11, and I immediately fell in love with this country. Right? The freedom to be anything you want to be. And given my mom's background, never for one day did I take my education for granted. So I studied really, really hard. And not just for the grades, but recognizing what an incredible opportunity that I've been given to really learn about the secrets of the universe. I still remember the first time I got to look inside a human body. The excitement that I had, probably the same excitement that y'all had, but just maybe made a little more special because I realized that I was the first person in a long line of family history that got to look inside a human body. So for me, knowledge is magical. It's powerful. And decades later, I still read for hours every night before I go to bed. And so that thirst for knowledge, that love for learning, has really taken me far. It took me to Stanford for college, where I studied political science and human biology, and then got a full ride to Harvard, where I studied public policy at the Kennedy School, then went back to California in a joint medical program between Berkeley and UCSF, where I got my Master of Public Health in Epidemiology from Berkeley, and got my MD from UCSF. And while I was at Berkeley, my classmates and I started this clinic called the Suitcase Clinic, which is still running after more than 30 years. And the reason we call it Suitcase Clinic was that our initial idea was that we're going to pack suitcases full of clinic, and we're just going to go administer care to homeless people at People's Park. And we quickly found out that that wasn't really what they wanted. See, it was for a whole constellation of problems that are more urgent, for which that they defer healthcare. So we realized that we needed a different model. So we started reaching out to students and faculty at the law school to come and help us provide legal counseling. And we reach out to graduate students and faculty in the Department of Psychology to help us do crisis intervention. And we reached out to colleagues over at the optometry school to come and fit eyeglasses. And then we recruited a whole army of undergraduate students, many of them were pre-meds, to come and help us do caseworking, to help take our clients to the Medi-Cal office to get their kind of WIC vouchers and so forth. And then we have volunteers from the community, chiropractors, dentists, masseuses, beauticians. And every Tuesday night when before the clinic opens its door, we had a long line of homeless people, probably more than 50 at a time, lining up not to get health care. They wanted to get their hair done. They wanted to get their nails done. And then they found out there was health care there. And so they then said, well, I can get my tooth infection looked at. So that was really my first introduction to social determinants of health. And it really kind of broadened my notion of what being a doctor is all about. It reminds me of something that Dr. Jack Geiger, who's the founder of community health centers in this country, said once when questioned by a government bureaucrat about why he was spending federal funds prescribing food rather than medicine. And he simply replied that the last time I checked my textbook, the specific therapy for malnutrition was in fact food. But then, while I knew that we weren't making a difference, it always bothered me a lot that it just felt like we were just putting a Band-Aid on the problem. It really didn't make a whole lot of sense to me that we would take care of someone for their asthma or bronchitis and would just throw them back out on the streets again. It seems like in the richest nation on earth, we should be better than that. And it reminds me of something that my mentor once told me, paraphrasing the quote from Primo Levi, that the mark of a civilized society is that it does not allow the powerful to become too powerful and the weak to become too weak. So after med school, I did my residency training in OBGYN at UC Irvine, and then joined the faculty at UCLA right out of residency, where I held a joint appointment between OBGYN and public health for about 15 years. And during those first couple of years as a junior faculty, I was floundering. I was like any assistant professors, you're chasing money and chasing data. I just wasn't really doing anything inspiring, and really wasn't sure whether I was actually cut out for academia. And this went on until one day, one of my senior colleagues stopped by my office, and he had agreed to do a presentation at a statewide meeting for the county health officials in California to talk about racial ethnic disparities in birth outcomes. And he couldn't do it, so he asked if I could take his place. And as he was leaving my office, he said, just tell them it's all about socioeconomics. Just tell them it's all about socioeconomics, which actually was a very popular explanation at the time. Right? That racial ethnic disparities were all about socioeconomic differences. So I started preparing for this talk, and as I started kind of looking at the data, I came across this, which just didn't make a whole lot of sense. Sure, African-American women who were college educated had better birth outcomes than African-American women who didn't go to college. African-American women with more than 16 years of schooling still had a much higher infant mortality rate than white women with less than 9 years of schooling. So I want you to pause and think about this for a minute. We're talking about African-American doctors, lawyers, and business executives, and they still had a high infant mortality rate than non-Hispanic white women who never went to high school in the first place. And as I started digging deeper into the data for all the other explanations, popular explanations at the time, such as differential access to prenatal care, or differential maternal behaviors during pregnancy, or even like genetic differences, they were just not borne out by the data. In fact, there was a study that looked at 46 different risk factors during pregnancy and found that these 46 risk factors explain less than 10% of the variance. Over 90% of the disparities went unexplained by these pregnancy risk factors. So that was kind of really where our field was around the turn of the century, that after all these decades of research, we still really couldn't explain very well what's causing racial disparities. And that's when I thought, well, maybe we're actually looking at this already. If you think about it, we were taking a snapshot of a pregnant white woman and a snapshot of a pregnant black woman, and we were trying to explain the differences in their birth outcomes based on these snapshots during pregnancy. Of course, we're not going to explain very much, right? Because we might know how good their nutrition is during pregnancy, but we don't really know about their nutritional status coming into pregnancy. Or we might know how good their access to prenatal care was, but we had no idea about their healthcare access across their entire life course. Okay? So that's when I thought, well, perhaps the way to look at disparities is not by comparing these snapshots during pregnancy. Perhaps the way to really understand disparities is by comparing their life course experiences, exposures. And that's the life course perspective that my colleague Neil Halfon and I wrote up for the Maternal Child Health Bureau back in 2003. And the life course perspective has two major components: an early programming component and a cumulative pathways component. Now, the early programming component posits that experiences early in life, including those when you were just a baby inside your mother's womb, these early life experiences can influence your health and function for life. And this is really based on the work, the early work by David Barker and his colleagues, who found, through a remarkable series of studies, actually found this relationship between being born low birth weight and increased risk for heart disease, hypertension, and diabetes later on in life. Now, if I were to ask you, tell me some risk factors for heart disease, what would you tell me? Obesity, right? Smoking, cholesterol, genetics, low birth weight. How many of you have told me about low birth weight? What does being born low birth weight have anything to do with your risk for heart disease 40, 50 years later on? Well, what Barker and his colleagues hypothesized is that there are these sensitive or critical periods during which the function of an organ or system is being programmed, and if things don't go right, if something goes wrong with that fetal programming, then that organ or system may never function optimally over the entire life course. A simple minor example is that if you were to get under nutrition in the second trimester, when the pancreas and the kidneys are rapidly growing, you end up with smaller pancreas with fewer beta cells, or smaller kidneys with fewer nephrons. That may then increase your susceptibility for diabetes or kidney diseases later on in the life course. Now, as you can imagine, the Barker hypothesis is actually met with a great deal of skepticism and even some ridicule in our field. But over the last 20 years or so, there's been kind of this really a big growth of scientific evidence that's beginning to support this whole notion of fetal programming, or what we call now the developmental origins of health and disease. And I think what's really fascinating about this whole business of fetal programming is this phenomenon called epigenetics, which I know most of you are familiar with. Right? It's basically volume control for genes. You can turn up or down, you can switch on or off your gene expression based on your environmental exposure, especially those exposures during critical periods of development. And there are many different ways by which epigenetic modification works, but one very common way is simply by putting a chemical tag right in front of that gene. In this group, it's a methyl group, right? 1 carbon, 3 hydrogen atom. You put that methyl group directly in front of that gene, that blocks the gene from being expressed. Alternatively, if I were to remove that methyl group, then that allows the gene to freely express itself. So generally speaking, methylation turns down, turns off, blocks, silences gene expression, whereas demethylation turns on, turns up gene expression. And this study came out about that time, which I think really illustrate the importance of epigenetic modification to fetal programming. And some of you may be familiar with this study. But what do you see on this slide? Mice, right? You see some blonde and chubby mice, and you see some brown and slim mice. Do you believe these mice are actually genetically identical? And all of these mice carry a gene called the agouti gene, which basically confer their fur coat blonde. The same gene also causes them to overeat, which then confer a higher risk for obesity, diabetes, and cancer later on in life. But despite being genetically identical, researchers in the study were able to turn some of these mice from blonde and chubby to brown and slim simply by feeding their mothers a diet rich in folic acid during pregnancy. Now, what does folic acid have anything to do with this, right? Because you all know about folic acid and neurotube defect. Well, it turns out that folic acid is a very rich methadonor. So moms who ate a diet rich in folic acid basically methylated, silenced, blocked that obesity gene before the pup was ever born. So imagine that, someday being able to tell our patients that we know how to turn on those genes that's going to confer upon your baby good health and longevity, and turn off those genes that's going to cause heart disease, cancer, and diabetes before your baby was ever born. All right. So this is no longer the stuff for science fiction anymore, right? In fact, the cancer doctors are about 10 years ahead of us, right? They are already working with tumor suppressing genes and tumor promoting genes. Although I do have to caution you against extrapolating too much from one animal study, right? Because not all humans are rats, but that's certainly one of the earliest and best examples of how early nutrition can influence your DNA methylation, and that such epigenetic changes can have lifelong and perhaps even intergenerational impact on health and function. And the second component of the life course perspective is the cumulative pathways model, or more commonly known as weathering. And what it basically says is that chronic stress, and we're talking both in terms of biological stress like an infection or malnutrition, or psychological stress that you get from just chronically living in an environment of poverty and violence and racism, that chronic stress can cause wear and tear to your body's organs and systems, which over time causes a more rapid deterioration in your health and function. And how does that happen? Well, what happens to your body when you're under stress? What happens when you see a saber-toothed tiger? You run, right? And what helps your body run faster is your body sets out all the stress response, right? Your hypothalamic pituitary adrenal axis and your sympathomedullary system. You're putting out all of these stress hormones to help you run away from the tiger. What happens after you got away? Your blood pressure comes down, your pulse comes down, you relax. And that's the amazing thing about the human body, that it's self-regulating. It knows to shut itself off once the stressor has been removed. And that's called allostasis, which means to maintain stability through change, to maintain stability through change. And allostasis works largely by a negative feedback mechanism that's common to many biological systems. Actually works very much like a thermostat, right? So let's say that the temperature in this room falls below a preset point. What happens? Well, the thermostat kicks in the heat, right? But as soon as that preset point is reached, what happens? The heat turns off the thermostat to prevent this room from getting overheated. Okay? So it turns out that same thing actually happens inside your body, that when you're stressed out, when you're under stress, your body kicks in HPA axis to produce cortisol. Cortisol in turn feeds back negatively onto your brain to turn off your HPA axis to keep your stress response in check. So allostasis works well for stress you can either fight off or run away from. But what happens if there's nowhere to run? What happens if you can't get away? Well, you get eaten, right? But if you don't get eaten, in the face of chronic stress, your body loses that ability for self-regulation, so now you can turn it on, but you can't shut it off. Biologically speaking, what may be happening is you get this tonically elevated level of cortisol, which start to down-regulate glucocorticoid receptors, so you start to lose that negative feedback, and we find in humans and animals who are subjected to chronic and repeated stress, they actually walk around with higher circulating levels of stress hormones. And if you were to subject them to some natural experimental stressor, that would put out a lot more stress hormones than people naturally would. And that's when you start to go from being stressed to being stressed out. Okay? There's actually a big difference here. Right? It's a difference between protection and damage. Okay? Because under acute stress, your body kicks in a sympathetic response to increase your cardiac output to help you run away from the tiger. But when you're stressed out, you can't shut off that sympathetic response, and that chronic, uncontrolled sympathetic activation over time can lead to hypertension and cardiovascular disease. Under acute stress, your body kicks in the HPA axis to produce cortisol. And cortisol is a glucocorticoid, and one of the main functions of glucocorticoid is actually it converts your body's stored energy into glucose, which then becomes readily available fuel to help you run away from tiger. And does that partially by impeding insulin action. But when you're stressed out, you can't shut off that HPA axis, and all those excess glucocorticoids over time can lead to glucose intolerance and insulin resistance. Under acute stress, your body's immune function actually works better. As you all know, under chronic stress, you become a lot more susceptible to infection and inflammation. And the way to think about this relationship is think of your HPA axis as a set of brakes on your immune system. Okay? So when you're stressed out, that's like just driving with your foot on the brake, right? What happens to the car when you drive with your foot on the brake? It just doesn't drive very well, right? And that may explain why women who are under chronic stress are more susceptible to infections and become more susceptible to preterm birth. But if you keep driving with your foot on the brakes, what's going to happen over time? You're going to wear out those brakes, right? And now you have a much bigger problem. You can't stop the car, as in the case of runaway inflammation. And think about all the chronic diseases in our society today that's characterized by excess runaway inflammation. Hypertension, diabetes, heart disease. And think about all the chronic diseases that are characterized by some racial disparities, like lupus, nephritis, the autoimmune diseases. And do you think that chronic disease may actually play a role in the pathogenesis of chronic diseases and the origins of health disparities in our society today? And lastly, under acute stress, you actually get growth of neurons in the hippocampus and the prefrontal cortex. These are learning centers inside the brain. It's almost as if they're designed to help you learn from your mistakes. And that's why I'm pretty sure that most of you can still remember vividly exactly what you were doing when you heard about 9/11. And that some of you could probably still remember exactly what you were doing when you heard that JFK was shot or Dr. King was shot. Okay? So under acute stress, you get growth of neurons inside these learning centers in the brain. Under chronic stress, the exact opposite happens. But rather than growth, you get atrophy and death of these neurons. And that perhaps explains why women who are under chronic stress begin to report that they're becoming more forgetful, that they're losing their memories. So Bruce McEwen of Rochester University provides perhaps the best illustrations of these concepts of allostasis and allostactio in this cartoon here. Okay. So in this bottom image here, okay, this is a picture of allostasis, right? Two kids balancing on the seesaw, maintaining stability through change. But what if we were to replace these two 5-kilogram kids with these two 500-kilogram sumo wrestlers? You put so much stress and strain on a seesaw that sooner or later the seesaw's going to break. And what if a woman were to enter pregnancy carrying these two 500-kilogram sumo wrestlers on her back? She's not going to have a very good pregnancy, is she? So all of this led us in 2003 to propose perhaps a different way of looking at health disparities using the life course perspective. That birth outcomes are the end product of not only the 9 months of pregnancy, but the entire life course of the woman leading up to pregnancy. And that disparities in birth outcomes are the consequences not only differential exposures during pregnancy, but differential early life experiences and cumulative weathering over the life course. The implication of this for practice and policy is that improving birth outcomes and reducing disparities will first require improving women's health, not only during pregnancy, but before pregnancy, between pregnancy, and across their entire life course. And that's going to take a lot more than just healthcare, right? It will take improving the social conditions and addressing all the social determinants that cause all that wear and tear, that cause all that weathering across their life course. So and my colleagues and I follow up that paper a few years later by proposing a 12-point plan to close the black-white gap in birth outcomes. Now, we did it not because we had all the answers, but we just want to provoke a different national conversation about how we go about addressing disparities. And I'm not going to go over all 12 points. You see the first 4 points around interconception, preconception care, quality of prenatal care, and expanding healthcare access across the life course. These 4 points move us beyond our current focus on prenatal care to addressing the healthcare needs of women and families across their life course. The next 4 points around strengthening father involvement, enhancing systems integration, creating reproductive social capital in the community, and investing in community building. These 4 points move us beyond our current focus on trying to change individual behaviors to talking about strengthening families and communities. And the last 4 points around closing the education gap, reducing poverty and supporting working families and undoing racism. These 4 points move us beyond our current focus on the biomedical model to start addressing the social and economic inequities that underlie much of our health disparities. So the 2003 paper that Dr. Halfon and I wrote ended up to be a pretty popular paper. It's been cited, I think, more than 800 times. It's the most often cited paper in maternal child health in the last decade. And in 2010, the paper was also credited for bringing about a paradigm shift in maternal child health. Now, the point I want to make about this is that if you think about it, all of this came by almost by accident, right? So if my senior colleague didn't dump his talk on the junior faculty, and if I didn't bother to look at the data, or if I just simply dismissed the anomalies I saw, then perhaps things would have been very different. So the one thing that I would ask you all, especially the fellows and the residents who are now going to become our next generation of scientific and intellectual leaders, is that just don't accept the conventional wisdom. Okay? Keep asking questions. Keep challenging assumptions. Okay? Especially as the life course perspective becomes the dominant paradigm, keep asking questions about it. Okay? Don't just dismiss the anomalies. And look at the data critically, because that's how we're going to advance science. That's how we're going to accelerate discoveries, and that's what's going to move closer to the truth that we're all looking for. So in 2012, I left UCLA to head up the Maternal and Child Health Bureau. Some of you may not be all that familiar with the Bureau, but it's the one federal bureau that's responsible for improving the health of all America's children and families. So I had a staff of 200, annual budget of $1.2 billion, and a portfolio of more than 100 programs that serve more than 57 million women, children, and families in this country. And as the director of that one bureau that's responsible for improving the health of all America's children and families, I think it's a national disgrace that so many kids and families in our country are still doing so poorly, that we are the richest nation on earth, and we consistently rank near the bottom on most standard measures of maternal and child health. I really thought that we could do better. So during my 6 years at the Bureau, we worked really, really hard. And it's not just me, the entire Bureau, all of my staff worked really hard at improving, innovating, and transforming all of our programs so that we can do better by kids and families in this country. So much so that some folks were starting to refer to us as the Make Change Happen Bureau, which I was very proud of. So we led the transformation of the Title V Maternal and Child Health Program, which is the public health system for children and families all across the country. And with more than $650 million in federal funding, and with state match and overmatch, the federal state Title V program is a $6 billion enterprise every year. It is really one of the best vehicles that we have to drive improvements in maternal and child health in this country. Now, Title V was authorized under Title V of the Social Security Act back in 1935. It was converted under the Reagan administration to a block grant in 1981, which gave the states a great deal of flexibility. And maybe rightly so, because certainly the needs of kids and families in Maryland might be very different from those of kids and families in West Virginia. But unfortunately, some states mistook this flexibility as a blank check to the states with very little accountability, and just did whatever they please with the money that they got. And so with each state doing its own thing, it was actually really, really hard to tell a coherent, compelling national story about what Title V was doing and what difference it was making. And so in 2012, the first year that I was there, Congress proposed, fortunately unsuccessfully, to cut the block grant by $250 million. And then the next year, when I got my president's budget, the president's budget proposed to cut us by $350 million. Now, that's our own administration, so to me, that's a vote of no confidence. Right? So we knew we had to change. So we got all the states and stakeholders together, and we led them on a collective visioning process about the future of Title V. It took us 21 months. We actually had lots of town halls and listening sessions, created an email box that got more than 1,000 emails and read and responded to every single one of them. But after 21 months, we got everyone to agree on a set of 15 national performance measures that all states are going to be working toward moving the needle on over the next 5 years. And we insisted that for each one of these performance measures, that they should be guided by a clear logic model and the best science and the best evidence. And then we completely revamped our national survey of children's health so that we can provide each state with how kids and families are doing in their state on an annual basis so that we can have real-time data to drive real-time improvement. And in the process, we transformed the block grant from what was perceived by many as a blank check to the states into one of the most evidence-based, one of the most results-driven block grants in federal government. And Congress took notice. So the same committee that tried to cut us by $250 million only a few years ago is now adding more and more money. It's added about $20 million over the last couple of years to the block grant. one of the things that you may hear a lot about is something called result-based accountability. Accountability is all about measuring and delivering results. It really starts with asking three key questions. Okay? What are we trying to accomplish? Which means having clear goals and smart objectives. How are we going to accomplish it? Which means having clear strategies guided by a clear logic model and the best science and best evidence. And importantly, what will success look like? Which means having clear metrics and robust data and having the kind of real-time data to drive real-time improvement. We also led the transformation of the Healthy Start program, which is the largest federal program to reduce infant mortality in this country, with more than $100 million to serve about 100 communities all across the country, including right here in Baltimore, serving some of the most vulnerable children and families in some of the most underserved communities in this country. But again, the program was established back in 1991. But for more than 20 years, Congress has this preferential clause right in the legislation, which means that year after year, the same grantees, the same communities get funded, whether or not they were producing results. In fact, when I first got there, there was a community that was getting over $1 million a year, but couldn't tell us how many families they were serving. So when I pushed really, really hard, it came back and said, well, maybe 25. But we're not sure if these are unduplicated numbers. Are you kidding me? $1 million for 25 families? But then I was warned not to go there, right? Because this Healthy Start program was backed by a very powerful senator. So we decided to transform the program. Okay? So we wanted the practice to catch up with science. With a focus on promoting women's health, not only during pregnancy, but before and beyond pregnancy. We worked on improving quality and safety of perinatal care. We worked on strengthening families, including fatherhood and communities. We worked on addressing social determinants and working across sectors and across silos to achieve collective impact. And we worked on increasing accountability. So for the first time in about 25 years, we had a real competition. And for the first time in about 25 years, we actually set performance measures, set benchmarks for our grantees. Now, as you can imagine, that the rollout was pretty bumpy. Okay? In fact, about a third of grantees, former grantees, did not get refunded. And so for about a year, I kept getting hauled into Congress for a whipping by members whose district lost their Healthy Start program. But I still think that we did the right thing. Because now the program is now serving more women, more families than it ever did in its previous 25 years. And infant mortality rate for the first 2 years after the transformation, so over a 24-month period between 2015 and 2016, was 5.0. 5.0 deaths per 1,000 live births. Now remember that most of these programs were eligible for Healthy Start funding by having an infant mortality 1.5 times that of national average, and more than 96% of grantees actually had a baseline infant mortality of 10 or greater. To go from 10 to 5 in just 2 years, that's huge. It's unheard of. Now remember I just said to look at the data critically? Okay. So I had my healthy skepticism about self-reported data. So in 2017, we went for the gold standard, right? So we linked birth death certificates, working with the National Center for Health Statistics. We also worked with CDC to oversample plans and develop a scientifically rigorous evaluation plan so that we can clearly demonstrate the true impact of Healthy Start. Now, I mentioned collective impact earlier, and let me just take a moment to talk about this, because I said earlier that if we really want to do something about improving birth outcomes in this country, we can't just do healthcare, right? We got to address the social determinants, and that means that we got to get out of our comfort zone and reach across silos and across sectors to work with housing and education and jobs and community development and economic development. Easier said than done, right? The expectation that somehow collaboration will occur spontaneously is the reason why most collaboration fail. And there's actually a science around how to do collaboration now that's based on 5 conditions. That you have to have a common agenda, you have to have shared measurement system, mutually reinforcing activities, continuous communication. Most important, you need to have that backbone organization with the right management skills and communication skills and budgeting skills to really help achieve the greatest collective impact. And that's really the model that we transform Healthy Start into, that they become the backbone organization for many of the communities that are trying to come together to solve their community's infant mortality problem. How are we doing on time? All right, so I'm going to skip this third story and go right to my conclusion here. All right, so one resource through all of these that I turn to again and again is this book by John Carter at Harvard Business School about leading change, which laid out an 8-step process for leading change that I found very useful. So for example, he said that a very common mistake for change leaders is that they start with the vision. He said that the vision can only take you so far if there isn't that sense of urgency for change. So you start by creating that sense of urgency. And I got lucky, right? There's nothing like a threat of a $350 million cut or the elimination of Healthy Start to create that sense of urgency. I think it's like Winston Churchill that said that you never want to waste a good crisis. Okay? He also talked about the need to clearly communicate your change vision. And you need to do it not just to the head, but to the heart. And he said that, again, a common mistake that change leaders make is that they start by talking about the vision and say, this is what I'm going to do, and this is how I'm going to do it. Okay? But instead of just talking about the what and the hows, we really need to start with the why. Okay? Why change? And make sure that people are on board with that. And there's actually a really interesting TED Talk about Dr. Martin Luther King and his I Have a Dream speech. That's kind of worthwhile for you to look up. And basically it says that Dr. King could have given a very different speech in that hot summer day in 1963. Right? So instead of saying that I have a dream, he could have said, I have a 5-point plan, right? Which probably would have been a fine talk, but it probably wouldn't have the same impact in terms of changing the conscience of a nation. And just one more example, that talks about the need to really have an early win, to really think about what your early win is going to be, because that allows you to create credibility for leading change. And I have to admit that when, I didn't use this example, but when the state health officials chose early elective delivery as the first strategy that they wanted to employ for the Collaborative Improvement Innovation Network with the coin on infant mortality, these are the 13 southern states that came together to do this. I just wasn't all that crazy about it, right? Early elective delivery is an important issue, but it's not the cause of the disparities in infant mortality that we see in this country. Okay? It turned out to be a brilliant strategy. Okay? Why? Because we actually saw the needle moved in real time in 18 months. That in 18 months, we saw a reduction of 71,000 early elective deliveries averted, translating to like millions, hundreds of millions of Medicaid dollars saved. And so that right away established credibility for the state health officials with their governors and with their state legislature, and that enable and embolden them to take on some harder issues that they did, such as addressing social determinants of health. All right, so I was actually having a real good time. Felt like I was making a difference. And I actually started to plan to launch this moonshot for MCH in the new Clinton administration. But then the election happened. I don't mean to be partisan here because the work that we do in MCH is bipartisan. And in fact, historically, MCHB has done better under a Republican administration than a Democratic one. But there's something very different about this administration that was very disturbing. And for me, especially given my background, that things like the travel ban, Charlottesville, family separation, and the hate, the bigotry, the racism that's been unleashed upon the land by the politics and policy and rhetoric of this administration, it's just not something I could continue to work for. So I resigned from the Trump administration last November, recognizing that I could probably do more good on the outside than from within. And for me, as perhaps for some of you in this room, these are dark days for a nation. It may seem that we're going the wrong direction, that we're moving farther away from a more perfect union. And at times like these, it's easy to get cynical about our future, to get disengaged from what's going on. It's precisely times like this that we can't give up, that we have to keep on working, believing that our nation's best days are still ahead of us, that the arc of history is long, but it will bend toward justice, and that one day this nation will rise up and live out the true meaning of its creed, that we hold these truths to be self-evident, that we're all created equal. Here I'm reminded of something that my friend Magda Peck did one year when she was on sabbatical. Magda Peck was the founder and former CEO of CityMatch. So Magda actually went around the country interviewing some of the greatest heroes of public health in the 20th century. People like Julius Richmond, who founded Head Start. People like Bill Fahey, who helped eradicate smallpox from the face of the earth. And after she conducted all of these interviews, she said that there's one thing that they all share in common. There was one characteristic that characterized all of the greatest heroes of public health in the 20th century. And that was what she called an unwarranted optimism. That they stay optimistic in good times and in bad. And here I'm also reminded of a parable that I grew up with in Taiwan about an old man who one day just decided with the help of his family to start digging away at this mountain that obstructs the way between his home and his field. And when mocked by a wise man about the futility of his effort, the old man simply said, I myself may not be able to move the mountain, but my children and my grandchildren will continue this work, and one day the mountain will be moved. So let's start digging, right? Let's move mountains. And if you didn't find anything that's worthwhile from my life story, I'm just going to leave you with kind of one message. Okay. Keep on believing. Okay. Keep on believing because that's who we are. That's what we do in MCH. And keep on believing because we have to. Kids and families all across the country are counting on us. Let me give you one more reason to keep on believing. Okay. Back to the start. right? I told you about where I came from, told you about my life story, told you about mom who had to drop out of 5th grade to go work in the factory, mom who had to sell her wedding ring to pay for my medicine. So I certainly didn't come from an educated family or a wealthy family. But none of that mattered anymore once we came to this country. And it didn't matter because of the version of America that I got to live in. Because in that America, you don't have to be rich to go to the best schools. And in that America, everyone gets a fair shot, no matter where they're from, what the family they're born into, okay, or the color of their skin. And in that America, I knew that if I just work hard enough and try hard enough, I can give my children a better chance in life. Okay? The kind of chance that my mom couldn't even ever dare dream of. And that my 2 girls, the granddaughters of a girl who had to drop out of 5th grade to go work in the factory, can now grow up in a nation where they get to be anything they want to be. That's what truly makes this country great. And that's the America that we're all fighting for, right? That's the version of America that we all believe in. An America where everyone's created equal. An America where every child gets a fair shot. Now, you and I, or maybe you and I, we might never get there ourselves. But let's keep digging, and let's keep working, and let's keep believing. And one day, our children and their children will get there, get to the promised land. And ultimately, that's what our work in MCH is all about. Thank you very much.
Thank you. Any questions?
I just actually wanted to thank you for talking about politics, because I think sometimes speakers are afraid because they don't want to, upset anybody. But I was actually going to ask a question about politics before you brought it up. So I greatly appreciate it and was beginning to become a little cynical. So I appreciate the being optimistic and giving us something to do, because I think that's part of the reason for the cynicism, is feeling helpless and unable to make a change. But I think that your speech was fantastic in helping us find a way to get more involved in being part of that change. So thank you.
Any other questions? It's a quiet group today. Well, thank you so much. I really appreciate it. Thank you so much for the work you do.